Welcome to the Growing Rural podcast, where we focus on all things rural in South Carolina. We will discuss topics on healthcare, economy, education, and the unique culture that is our rural state. This podcast is supported by the South Carolina Center for Rural and Primary Health Care. Please join us for today's topic.
Hello, everyone. Welcome back to the Growing Rural podcast. I'm your host today, Dr. Kevin Bennett. Our guests today are Drs. Caughman Taylor, Dr. Shuler, and Dr. Staples. And these are three physicians from University School of Medicine and PRISMA Health Pediatrics who are going to talk about a pediatric subspecialty program that they have been doing for many years now. So welcome, everybody.
Thank you.
Thanks.
Good to be here.
So real quickly, I'd love for each one of you to kind of introduce yourself and talk about how you came to Columbia and doing this work.
I'm Heather Staples. I'm a pediatric pulmonologist here in Columbia. I came to the area initially to do my pediatric training. So I was a resident at PRISMA Health Children's Hospital, went away to train in pulmonology, and came back about 2.5 years ago to join the faculty, and I've been enjoying it ever since.
Great.
I'm Ozzie Shuler. I'm the chief of pediatric cardiology. I've been here in Columbia now for almost 26 years. I went to undergraduate at USC, did all my medical training down in Charleston, and then came back to Columbia to do to work. So, having grown up in Orangeburg and gone to undergrad in Columbia and medical training in Charleston, I kind of know the state, and I've seen about everything rural about this state in my lifetime. And that's one of the big reasons that I first started doing my rural outreach clinics, was because of my connections to the rural part of the state.
Great.
I'm Caughman Taylor. I'm chair of pediatrics. I've been here for over 40 years, resident medical student, and been the residency director, pediatric hospitalist, and then chair, now also senior medical director of our children's hospital.
Yeah, that's quite a bit.
A long time.
Yeah, that's what happens when you stick around somewhere for a while, right?
Or they don't fire you.
Right. So, Dr. Taylor, tell us a little bit about how these outreach clinics started. What was the impetus behind that, and what all do you guys do exactly?
Yeah, and so as Dr. Shuler alluded to, it was part of what he and his division had established with, they were doing outreach clinics specifically in cardiology. And so it fit with our mission of trying to provide the best care locally, our mission to try to serve all the people of South Carolina, and our recognition of the lack of subspecialists in and around the areas we served. Mm-hmm. So we basically probably modeled ourselves after what Dr. Shuler was doing, and then when iCare came along and offered support, that was a genesis to allow us to expand significantly. Probably at that time, I'm not sure we were doing maybe more than 2 other subspecialties at most. Dr. Shuler could comment more because in his role as vice chair, he kind of oversees our rural health program and helps me coordinate that. Mm-hmm. So that's kind of how we started, and it was just trying to serve. We realized how difficult it was for families to travel. I mean, 45 minutes, they had to take the whole day off to travel, where if we could be right there, then that allowed them to get the care that day. And I'm sure we'll talk more about how the success of the program. Ozzie, you want to add anything more about how we got started in the program? And
to clarify, we're talking about taking physicians and clinical teams to a local rural community to provide care in location.
Yeah, we take everything. We take our staff. We have our equipment. If it's pulmonary function tests that Dr. Staples and her team use. In the case of Dr. Shuler, they got EKG and echo machines. We've got the nursing. And we built off of that, but they all get in a van or get in a couple of cars and they drive to the locations. Right. And we use a myriad of locations that we can talk more about and have taken advantage of what was offered. Sometimes we pay rent, sometimes we do it in a private office, sometimes we have established with the program support that we've gotten here at the university, being able to actually rent a building full time in one of the areas we're there all the time with.
Right, yeah. Yeah, so Dr. Shuler, tell us about how you kicked all this off, apparently.
I can tell you the day we did our first outreach clinic, it was April 19th, 1995.
Okay.
And the only reason I know that is because my longtime nurse, Helen Palmer, reminded me of this, that it's the day that the Oklahoma City bombing occurred. And it was on the TV in the lobby of Dr. Mac DeBoe's office in Sumter. He was a family practitioner in Sumter, and he let us use a few rooms in his office to do our first clinic. We saw 5 patients. And right in the middle of clinic, the TV came on with the announcement of the Oklahoma City federal building bombing. So that day will live in infamy in this country, and it's a way I remember when we did our first clinic. And that's how it really all got started. We did Sumter. We then added on Lancaster and Orangeburg, and eventually started going to Aiken as well. As far as where we picked the clinics, it was kind of based on our rural background. Dr. Luther Williams was my partner at the time. He and I both joined the university at about the same time. He grew up in Lancaster. I grew up in Orangeburg, so we ended up with a clinic in both places because we knew people.
Right.
It's all about who you know in South Carolina.
Right.
And Sumter was a very easy location to pick because of it's a major referral area for our practice.
Right. So it was a combination of people that you knew, but also you knew that a lot of folks from there came to your clinic.
Exactly.
Yeah,
that makes sense.
And Kevin, I think, before we got the support from the South Carolina Center for Rural and Primary Health Care, Dr. Shuler alludes to is about the relationships, but the private physicians wanted us there because we could see their patients for that. And so it did get more sophisticated, as you've alluded in the conversation, that we started looking before we start satellite clinics now, or rural health clinics or our outreach clinics. We have 3 different names. But before we do that, we look and see how many patients we have in that subspecialty.
Right.
Is that a reasonable thing to do? And then we increase our volumes from once a month, or from every other month to once a month to twice a month, based on those volumes. So we are very cognizant to look at how many patients in that given subspecialty. And that's why right now we're kind of not mismatched, but we don't necessarily send every specialty to every rural health location that we have or every outreach area that we have. It's based on the numbers of those patients.
Right. It's all about supply and demand, I guess.
Yes.
Business terms, right? Which makes sense, but then, you're providing services in that location, and now patients can, the Orangeburg clinic, for example, that's not just patients in Orangeburg, right? That's people from further out from Orangeburg coming in, right?
Yeah, it's funny when you talk about what's rural. And
Right.
It's all relative, I guess. If you
Yes,
ask
it
someone
is.
from New York City what's rural, they'd probably tell us the whole state of South Carolina. But
Right.
if you look at Orangeburg and Sumter, you say, well, those aren't really rural locations, but they service very rural counties that sit right next to them. Orangeburg's
Correct.
right next to Calhoun and Bamberg and Barnwell counties, and Sumter right next to Lee and Clarendon County. So those are definitely rural parts of our state.
And when those folks seek care, they go to town and they go to Sumter,
Exactly.
not Columbia.
They don't want to drive. They don't want to drive on the interstate and come to Columbia.
Right,
as they tell
exactly.
us.
And I don't blame them for that necessarily. So, Dr. Staples, tell us a little bit about, your work. You're the provider. You're not involved in setting them up necessarily. You're actually delivering the care to these patients. Tell us what that looks like for you as a provider. And you said this is one reason why you wanted to come back and work here, right?
Yes. So one of the things that really drew me back to the position here in Columbia was the ability to serve patients who had needs that they had difficulty getting into the mainstream part of the state. So when I first started, I was going to Florence once a month and to the Lancaster area once a month. And again, like we were just talking about, Florence may not sound like a rural area, but I have a lot of patients in Dillon.
Right.
And Dillon is much farther away from Columbia than Florence is, but
Right.
patients can get there easier than they can get to Columbia.
Right.
So initially we looked at, and for about a year, we actually were going to Fort Mill to see patients on the north side of the state in the York County area. And then, like Dr. Taylor was saying, we really keep an eye on the number of patients and how we're serving that area, and found that I was getting more and more referrals from the Florence area, and my clinics were more and more booked. So we ended up pulling in the Fort Mill area to the Lancaster clinic and opened a second day every month in Florence. And those days are booked several months in advance.
Wow, okay.
Oftentimes we end up overbooking just because it's so difficult for the families to make the trip back to Columbia.
Right.
But a day for us includes the team meeting pretty early in the morning and caravanning out to our location. For our team, we have myself, we have a respiratory therapist, a nurse, and then an office staff who works with us on checking in patients and scheduling patients. And it goes so smoothly. I mean, it's a well-oiled machine. And it's nice because there are a lot of patients that need to be seen regularly for follow-up. And so we're able to just see a whole list of patients in one day. And it makes it so much easier for them. And I know typically when I see them for their first visit, I'll ask them, did you know I see patients in Florence? And most of the time, if they don't know, their face lights up and they're like,
Right.
oh, I didn't know. And I was like, yeah, I can see you there for your follow-up appointments.
Right.
And you can tell that really means a lot to the
Yeah,
families.
that's a huge difference. So how many patients would you see in a typical day? over there?
I usually have 17 slots between 8:30 and noon. So they're 15-minute slots, so we see follow-up patients there. I don't see new patients at this time in the outreach clinic. But we will typically book 3 in our last slot so we can get in as many as we can before we
Right.
go back to Columbia.
Right.
So yeah, usually we have around 15 that end up showing up.
Okay. That's still a pretty good.
Oh, yeah.
That's a full morning.
It's a full day that we do in a morning.
Right. That's a good way to put it. So, tell me a little bit about who these patients are. Like, why are they seeking the care, and what is it about the local care that they value?
So it's the same disease processes that we see with the patients who are in Columbia. We have patients with asthma, cystic fibrosis, former preemie babies on oxygen who may require trach or vent support. The thing that's different is that these families have to take off a significant amount of work time to travel, the cost of gas, and then meals if they're going to be gone for several hours.
Right.
And a lot of our families the parents are hourly wage earners. And so to lose an entire day's worth of work is detrimental significantly to their families.
Right.
And so for them, being able to be seen locally is huge. And I have found that some of my complex patients who were chronic no-show patients actually are coming when they don't have to have the burden of travel.
Right.
Because that is, I think sometimes we underestimate the cost burden to these families, both the time and the money cost.
Yeah, that's a big deal right there. And you said you see mostly follow-up patients at these clinics. Is there a reason for that, or is it just because of the complexity issues, or?
Yes. So a new patient has potential unknowns. So you're not sure what the complexity is. There have been many times that I've admitted a new patient directly to the hospital because we didn't realize with them coming in what their needs were going to be. Sometimes those are longer visits than you anticipate, and sometimes we need our more sophisticated pulmonary function testing equipment that we aren't able to take with us to the outreach clinic.
Right, so that makes sense. And then once you've done that, then you know what to expect, and you
Correct.
can book them there. That makes sense. Dr. Shuler, back to you. I'm wondering about, some of the cardiovascular conditions you're seeing. We're, again, resetting this. We're talking about pediatric patients with pulmonology problems and cardiology problems. That's not the norm that you think about when you think about cardiology.
Yeah, when you think about cardiology, you think about old people who have
Right.
heart problems, but it is the most common congenital anomaly that we see is cardiac anomalies. And the clinics that we do have a fair amount of kids who have potentially fairly complex heart defects and those are the ones I think in some ways it is the most meaningful to them, because some of these kids between their surgical stages, they need to be seen every 3 months for the first 3 years of life. That's a lot of travel for someone who's coming back that frequently. So those patients really appreciate the clinic. We also have some babies who have rapid heart rates that we have to see once a month to adjust their medications. And if you're talking traveling to Columbia from Lancaster once a month, that's a big hardship. So those are the ones that makes a huge difference. And as Heather was referring to, the ones I think it makes the biggest difference to are the people with limited resources. You hear stories about, I can borrow my brother's car, but I can only go 10 miles in it, or he won't let me use that much gasoline to come to Columbia. And those are the ones that if we weren't close, they just wouldn't be coming.
Right.
And we know that from our numbers. And looking at show rates, we just have so much better show rates, like Heather was talking about in these outreach clinics, than we do when these same patients come to Columbia.
Yeah. And so if they end up not seeing care with you, happens to them?
They end up in the ER because their medications are subtherapeutic. They end up getting admitted to the hospital because their asthma is now out of control for Heather's patients. So it makes a huge difference, and it probably saves the state and the families a lot of money in the long run to get this regular care.
Right. And just the peace of mind, I guess, to be under therapeutic control is a huge, huge thing.
Yep.
So, Dr. Taylor, I know you mentioned earlier, this has expanded over the years. We started off with a handful from Dr. Shuler, and now where are we? How many clinics are we working on? How many providers? How many patients?
So we are up to about 9 subspecialties that we provide, and it varies. We've gotten up to 7 or 8 locations, and depending on the number of patients or what's going on, we may drop a Fort Mill or add a Lancaster, and so we're very aware of that. So we're up to about again 9 subspecialties, and everybody's different. I mean, pulmonology probably provides the most. They have 5 sites in general. Cardiology and others are doing 4 or so, aren't you, Ozzy, at different locations. And so we just keep adding, and like we've got we've added our first pediatric physiatrist, but we've had to wait till the second one come, and we're now going to start doing those. So that will be an additional subspecialty coming up soon. That will be more locations possibly that we will choose to do, or in some of the similar areas, because if you look at us, we're kind of a spoken wheel, and as you've said, and Ozzy and Dr. Staples, those spoken wheels and extend out from Sumter or Lancaster to true rural areas, and so our whole goal is to do it in those locations. And I know we're only talking about the Midlands here, but the upstate, because of the South Carolina Office of Rural and Primary Health Care and the money, the upstate started this program now. Right. And so they have satellites in places like Anderson and think Oconee and others. And one unique thing that I think we do with our program that helps another health system uniquely is what we're doing in Florence with our subspecialty. In fact, we've agreed to provide more subspecialty clinics there. And as Dr. Staples alluded to, they're going to see that child in their hospital, whether it's in their PICU or their hospitalist service. That child would maybe have to come all the way to us, and so we're adding telemedicine so that maybe we can see that clinic child. If we're having HEMONC clinic, for example, maybe Heather could do, Dr. Staples could do a follow-up clinic that day for their asthma and not drive. She'll have to determine based on the consultation. But we're using telemedicine piggybacking, and our next step, and Dr. Shuler maybe can talk more about it, but our next step is we're trying to hire enough nurses and staff so that if pulmonology's there, if the need arose, we could also schedule 1 other or 2 other subspecialty patients to be followed up that day outside of the scheduled subspecialty, again, to provide better access, more convenience, so the family doesn't have to wait for 3 weeks for cardiology to come back, 3 weeks for GI to come back. And so we've also been very unique, and you mentioned COVID, and we'll get there, but we were already exploring using telemedicine because of our child abuse program and because of the work that we've done with the South Carolina Telehealth Alliance and putting that in there. So this was a natural evolution, I would say, wouldn't you, Ozzy and Heather, where we put telemedicine or building our telemedicine capabilities in all these areas. So, for example, Dr. Shuler has a partner, and maybe they used to take 2 providers, or he has several partners, but maybe 2 providers would go. Now 1 can go, 1 can stay in the office, but yet they could still see them via telemedicine and serve, instead of 10 patients that day, 20. So that is really helping us provide care. In South Carolina, everybody talks about nursing shortage, and everybody talks about primary care shortage, but the shortage of subspecialty pediatrics in South Carolina and nationwide is significant, and that has a lot of reasons. So these guys are like gold, and you want to try to put this gold arch wherever you can. And so this rural health program, along with telemedicine, is allowing us to give the best care locally, but subspecialty care locally. And and Dr. Shuler and Staples both have described how much of a difference it makes for those families with limited resources, travel.
Right.
If they're coming to Columbia and the Medicaid vans, transportation's an hour late, we may be shut down. Well, they aren't going to need that to come to Sumter, to Orangeburg.
Right.
They probably can get there on their own, and that
Right.
changes the game for that child
Right.
in terms of outcomes.
So I'm wondering about, you mentioned telehealth, telemodalities. Some people might say, well, why are you traveling to them? Why not just dial in? Why not just do a telehealth option? What's the advantage
I'll let
of
the
the
two guys
in-person?
who use it explain why that doesn't always work in children, okay?
It's funny, you hear people say occasionally, what good has come out of COVID?
Right.
If you point to telemedicine, we were kind of, everyone I think in the country was kind of messing with telemedicine before COVID, but COVID forced us to use telemedicine. One, to keep ourselves safe, and one, to keep our patients safe. And so we've expanded a little bit, but for us, we're more of our specialty in pediatric cardiology is based more on a lot on tests, EKGs and echocardiograms, and we can't do that over a telephone or a video conference. So we're somewhat bound by that, as is pulmonology with their pulmonary function studies. But outside of that, there's also it's very difficult with small children to do by televideo. They don't always cooperate when you're even in the room, much less
Right.
when you're 30 miles or 40 miles away. And the reality is there's still a great degree of hands-on medicine that needs to be performed. You can only auscultate so well over a telephone line or a video line. And I know that I struggle sometimes hearing heart sounds and murmurs very well over a telemedicine line. I'm sure y'all do with lung sounds as well. But I think there is a utility for it, and we've really explored that since COVID, and have tried to maximize it the best we can in creative ways.
Benefit of the way we've utilized telemedicine is what Dr. Taylor was referring to, where there may be one provider in the outreach clinic and one seeing patients by telemedicine
Right.
in Columbia. And that really allows for you to maintain the therapeutic relationships you've built with your patients. So we take turns taking call in the hospital and seeing consults, and sometimes you have a complex hospitalization. You spend a lot of time talking with that family, building a rapport with them, but they live in an area where your partner goes to outreach clinic and you don't. So what we've started doing is letting our patients come to that outreach clinic when, let's say, my partner is there. They can get their pulmonary function testing, but then I see them over telemedicine for the visit.
And they facilitated it in person.
Yes.
Yeah.
And that's nice, because then you can have that continuity of care with the patient, and they don't feel kind of jarred by, oh, are you sure this other provider knows my background? And
Right.
yes, they do. But it matters that the patients feel that
Right.
sense of security.
Right. And, I would imagine you guys have all mentioned this, the patient satisfaction with this, I imagine, is very high. And when you have children with chronic illnesses, I bet there's something valuable to seeing that provider in person, right? Better than through a screen.
Yeah, absolutely.
Yeah.
I would agree, and I think too there's that subtlety of pediatric medicine when you're trying to do a developmental assessment of a child, and that is so hard to do over a telemedicine platform, where you're doing these subtle testing or neurology differences. Well, these two specialties they've told you the difficulty they have in auscultation. Imagine when you're trying to assess a child's what we call tone, the resistance to movement, or assess their muscular strength. That's just impossible unless you lay hands on, and that's another reason often it's a follow-up visit. It works really well for those in terms of diabetic care and follow-up visits for neurology where you're adjusting medications and things like that. But as Dr. Staples said, you got to know what you're dealing with the first time to determine if you can let that child come back for telemedicine visit and or even an outreach clinic visit.
Right.
So it's still that not all patients, even though they live local, do we necessarily do that. And that's going back to what I was saying about our relationship with McLeod Children's Hospital. Us providing that subspecialty, but these guys have to make that decision about, no, based on how this hospital course went or whatever, I probably need them to come to Columbia first, but I'll see them all the time now for follow-up if we can.
Right.
And so the rural clinics and the telemedicine is just allowing us to do what you alluded to, which is provide the care locally and take the strains and stresses off the families.
Yeah.
And that makes it better for everybody. But as you said, Dr. Bennett, you've got to have that therapeutic relationship, and we as human beings still like, thank goodness, human beings and the actual presence of those people, not machines.
Yeah, those are great points. We've kind of mentioned this already, but the impact of COVID on this, I'm sure, was not minor. Pulmonology, cardiology, obviously big things in the COVID disease, but also all the restrictions and illness and things like that. I'm sure that impacted your delivery of care during that period. And even, I guess, we're September 2021. Still kind of in the throes of it, right?
So as Dr. Shuler said, within 3 or 4 days, we just had to change everything. And so we met a lot. The leadership met continuously in our divisions, and so we had to transfer all these visits that we could to COVID, and we due to COVID to telemedicine visits, and only allow emergency visits to come in, or urgent visits, or visits we could not. We didn't have PPE. You couldn't find it. And so, as Dr. Shuler alluded to, protecting not only our patients but ourselves, we had to come up with protocols. How do you not use a waiting room? We don't have beepers for them to take to the cars. There was a lot that we had to work out, and our team just did a phenomenal job over 3 or 4 days to get us there. And we still had some on-site visits, but and we've learned. The Delta variant hit us harder than we got hit the first time.
Right.
No doubt about it.
Especially among children.
Oh,
right.
yeah. This compared to where we were, this is so much bigger a tidal wave. But we adapted, and we had to do a lot. Satellite clinics maybe couldn't be held, or the rural health clinics had to be canceled for a while because we couldn't drive out there and have the PPE till we could get the PPE, and how do you get those patients in? And so logistically, we were all just, it was a minute by minute, idea by idea, solution by solution team effort.
The other part of the problem with COVID was that about half of our clinics we do in pediatricians' offices. We rent space from them, and so we share office space with our pediatrician colleagues, and we had to figure out what they were going to do. And some of their schedules, they would say, we're going to see COVID possible patients at this time, so you can't do a clinic at this time. So we had to move schedules around. So we had to work in conjunction with our pediatric colleagues to figure out how to get the clinics done logistically, as far as safe for the patient and safe for our providers. And another thing, that when we first started doing our cardiology clinics, we had giant ultrasound machines we had to carry with us because they didn't make portable laptop versions back then.
Right.
So we found a van. HEMONC had a van that we could use, so we took out a back seat and put our echo machine in the back of it and would go to clinic. And then we took that opportunity, since we're taking a van with us, let's take a medical student with us. So we started taking medical students. So now we get into COVID, and we're still taking medical students, and we're thinking, what's 6 feet distancing in a van? It just doesn't happen.
Right.
So for safety of the medical students and for our staff and faculty, we had to suspend taking medical students to our clinics with us. So there's a lot of different considerations. Now, once we all got vaccinated, we changed all that and made changes in the way we did things. But it made us think of a lot of different ways of doing things when we were faced with that. And again, if you look back at COVID, and what is good about COVID, though very little is, it really teaches us to think creatively and learn how to not just sit in the norm of what you do, but think outside the box.
So early in the pandemic, the Cystic Fibrosis Foundation, that is the group that puts out the recommendations for patients with cystic fibrosis, strongly encouraged that these patients not come into a healthcare setting. And that posed a huge challenge for us because we see these patients on a quarterly basis. And it's not just a check-in visit. We're doing checking weight, pulmonary function testing. We're looking at whether they have any new bacteria they're growing in their lungs, so we're having to get samples. This became very challenging and a huge discussion point nationally, but among cystic fibrosis providers on how to best do this. So we actually were brainstorming some options on how we could reach some of our patients, because some of them were even struggling to do telehealth. So we were talking with the powers that be at PRISMA, and we were able to utilize their mobile health unit, which is basically a tricked out, fancy looking U-Haul almost,
right,
that the inside looks like a patient room.
Right.
Well, the challenge was these patients on a normal day cannot interact with each other because you do not want their bacteria to cross-contaminate.
Right.
So we utilized the space, but we actually went to these patients' homes,
Wow.
set up outside the mobile unit, utilized the electricity and the Wi-Fi and everything, set up usually in their driveway or in their yard, and we spent hours mapping out who needed to be seen. I had big maps of South Carolina on my desk, patients' addresses, and trying to figure out, yes, how long would it take to get here? Oh, there's 2 siblings here. How long is that visit going to take? But we would set up our pulmonary function testing machine. We'd bring out the scale. We had, at that point, access to PPE. And so because we were utilizing pulmonary function testing, that's an aerosol generating procedure.
Right.
So we were utilizing N95s in all of our gear. But we were able to see probably a third of our patient, cystic fibrosis patient group over the course of 2 months. I think we utilized the mobile unit 5 or 6 times. So it was really loved by the families. I've actually been contacted multiple times saying, are you going to do it again during flu season?
Yeah, I can understand that.
So, but we really hit a lot of the outlying areas, like sometimes, an hour and a half out from Columbia, and we were getting some of these patients.
That's great. One thing I'm wondering about, you said you hit about a third, the past 18 months, how many people have kind of been left behind? Because even though you guys have bent over backwards to do everything you can, there's still gaps in care due to COVID, due to fears, due to, just everything. Have you seen that starting to trickle up your way yet, of folks who delayed care for too long because they couldn't get it and now they're having problems or that kind of thing?
We saw it in quite a few asthmatics who were very nervous about coming into the clinic, and so missed several follow-up appointments. Some of them didn't come into the clinic because they were nervous about coming into a healthcare setting. Others were quarantining so well that they weren't exposed to any triggers for their asthma, so they were doing
well.
Yes, but they went off all their medications, and then when they came out of quarantine, started having a lot of issues. So I've seen quite a few patients in that scenario.
Interesting. Yeah.
We see some cardiology patients who've missed several visits, and when they finally get them back in, it's always COVID and concerns about COVID. And these are genuine concerns.
Absolutely.
I don't think they're making excuses. They really are quite fearful of coming into an office where potentially other people could have be carrying the virus. So
these are already medically fragile folks,
exactly.
So that's very understandable. Yeah.
And I think 2 related phenomena related to COVID, but not necessarily impacting our rural health clinics, but did, was that, as Dr. Staples alluded to, people didn't get seen. Maybe they didn't have their asthma attacks or whatever, but a lot of kids delayed being seen in some areas, so their complications were higher because they weren't being identified by primary care physicians because they weren't coming in. So their diabetes wasn't identified as early, or their cancers, or their GI problems. But 2 things that did result directly from COVID, and I think are impacting our rural health clinic access and availability, is the surge in mental health issues. And that sometimes carries over to developmental issues. So the child has mental health issues, and it looks like they're developmentally having issues when really more some mental health issue. So the services in both in neurology and in our developmental clinics have been really pushed to the brink. And I also think we have unfortunately seen a lot more child abuse and neglect.
Right.
Because they weren't being identified in the schools. They weren't being identified by other people that are mandated reporters.
Right.
They weren't going to church. People were not being seen. And so I know in Children's Hospital, we have unfortunately had a lot more kids with suicide intent and suicide attempts. And the mental health issues and the child abuse and neglect issues have been overwhelming.
Right.
On one day in our Children's Hospital, I think of the 40 kids, I was told 27 had mental health issues. Now, not all, they weren't in the hospital for those, but they had depression or anxiety or worse, other disorders. And so that has challenged our rural health clinics, because in terms of going out, those first-time patients can't necessarily be seen with related disorders. So there was a certain flood as we alluded to with COVID, that we've never seen anything like it in our Children's Hospital. We have been 8 to 9 weeks now of no beds in our PICU, with 2 or 3 every night in our PZD. So the acuity post-COVID has spread out to our rural health clinics as well.
Right. Yeah, and it's an ongoing problem.
Yes.
How do you think that this whole COVID situation, which we're still in the middle of, how do you think that's going to change delivery, especially for you all going forward, good and bad?
One of the most noticeable things in clinic is we see a waiting room now as a detriment.
Right.
And we still, every time we have a flare or a peak, we tend to shift our patients back to the parking lot, and that's where our waiting room is. With cell phones, it can be done. It's a little more difficult, but I don't think I'll ever look at a waiting room again the same. You look out there and you've got 10 or 15 patients packed into your waiting room, thinking about what viruses they could be passing each other.
Right.
And the normal times of rhinovirus and this and that, it's no big deal. But when you're talking about COVID and influenza, it can be a big deal.
Right.
So I think that's changed how we think about handling patients in our clinic for sure.
I think it's also, we've alluded to it, we've talked about how telemedicine, so we adopted that. So I think our willingness to adopt new technologies, thinking outside the box, as Dr. Staples and they did, to use the mobile health clinic to make sure those kids' needs were met. And that's just not something we would have ever jumped to, I don't think, if we were not there. But yet we know we can do it, know how to do it on a moment's notice, if we know how to or need to do that. I think it accelerated us looking at how we protect ourselves. I think maybe you're going in for a heart thing, you're not thinking that much about infectious disease. Sure, he washes his hands, but we weren't thinking about that much as we are now, and the screening that will probably continue regardless on patients. And I think it's going to continue to have its ripple effects depending on how things evolve and what availabilities of things that we can offer to the patient to provide care. But as we've all alluded to, in the end, we have to touch that child at some point. We need to be in the room with them, but using our technologies, rural health clinics, to deliver care at the home, and these new technologies of, the things that both they do for sleep and pulmonary function and devices that can be used at home, I think will accelerate and allow them to download, as they do already, download data from home.
You mentioned behavioral health as a growing concern. What else do you see as something that is a issue or something coming that you are thinking about that is going to affect your patient populations?
I'm significantly concerned about these post-COVID syndromes that I'm seeing in particularly teenagers, but older children who have shortness of breath months after their possibly almost asymptomatic COVID infection. So I've had a rapid uptick in new patients who were sick with COVID and will describe a very mild course. And then for months after, they have shortness of breath. Some of them have chest pain. The challenge is that we bring them in, we do pulmonary function testing. Sometimes it looks normal, but some of them are responding to asthma medications. And so we have this whole new area of post-COVID disease that, especially with this newest surge, I have seen even just in the last 2 weeks, maybe half a dozen of those kids. So it's a new issue that we're dealing with, and I have a feeling we're going to continue to see more of that for a while.
Right, and that's a potential lifelong disabling condition of some sort, right?
And we're just not sure. And that's what I've been telling the parents and the patients, is that we don't know a lot about what to expect from this. A lot of times I can give parents some anticipatory guidance on how long I think we might need to treat X, Y, or Z. And I tell them, I was like, we don't know yet what this is going to look like. We'll just continue to monitor it. And if we feel like they can come off the medications, we'll do that.
When I was in medical school, and Caughman will remember this, there was this new disease called, what was it, human immunodeficiency virus. I've forgotten what they first called AIDS, but that was when we were in medical school and in residency. And now we've got this, it's been 25, 30 years since then, and now we have this new disease that who'd ever thought at this point in my career they would find a new disease. And then after that disease, we end up with all these post-disease processes or reactions that we had no idea were going to come until 3 or 4 weeks after our first COVID patients. We started seeing these unusual post-infectious processes. It is a little invigorating for your career to have something new like that come along, but it's also a great deal of challenges and a great deal of unknown, as Heather was talking about. We don't know what to tell people long term if you have one of these reactions. We certainly do know that every bit of data, and I'll throw this plug in there, every bit of data we see so far, it's a heck of a lot more complications from the disease than it is from the vaccine. The vaccine, we've seen rare, mild reactions to vaccines, but some of these acute cases of COVID and in these post-infectious processes, we've seen some really sick kids, and we're not sure how long they're going to last.
And, to follow up with that, it looks like coming soon we'll have vaccine approvals for 5 to 11-year-olds. Some of those myths out there, myocarditis, blood clotting, you have the floor. Please address those and educate us on why we shouldn't be concerned about that.
Yeah, I should be able to do it with my eyes closed and half asleep because I do it for every single patient that I see. But the summary of it is the complications from the vaccine are generally mild and extremely rare, and the complications from the disease are unusual, but are certainly a whole lot more common than we see with the vaccine. So I tell my patients, if you look at just the numbers, the statistics of what your chances are of getting a serious complication, take your risk with the vaccine, though it is very small, versus your risk with the disease, which is more significant and certainly more unknown than what we understand right now.
And another pervasive myth out there, how many patients have you seen in an inpatient setting or even in a physician setting that have a complication from the vaccine itself?
I can tell you that no child has been admitted to a South Carolina Children's Hospital for complication from the vaccine. And I can tell you that every child that's been admitted to our Children's Hospital, except one, has been unvaccinated.
Which seems pretty clear.
If you're, and that's the frustrating thing for me. Dr. Shuler's been a lot less kinder or whatever, but it's frustrating for me when I hear from some of my colleagues that this is a mild disease and you don't need to get it. Dr. Staples has alluded to the long-term complications that we don't know about. Dr. Shuler sees heart things that we don't know about. I am walking the floors and seeing all these little 2-month-olds, 6-month-olds that are on ventilators. I'm seeing kids come in the hospital for 5 to 7 days minimally and then have problems afterwards. I'm also seeing that kids are transmitting the disease to high-risk people, whether that's a child who has a complication or another one. And I just say, why? I mean, we vaccinate against measles, and it didn't, back in the old days when it was rampant, cause as much trouble as as COVID has done. We give flu vaccine because we recognize it's a high-risk disease to certain patient populations.
Right.
So to me, it's also a public health issue.
Right.
We vaccinate. I'm going to get the pertussis, the DPT thing, because I'm getting ready to have my first grandchild. I'm not going to get pertussis, but I'm getting it to protect my grandchild.
Right.
And so I think there's also, in peds, we've always been that way in pediatrics. So we don't know. Lungs are reshaping for so many for the first times in their life. Things are still growing compared to adults' hearts and things. But yet we know these kids end up in the hospital. Kids are in record numbers in the hospital compared to flu. No doubt about it.
Right.
And whether the death rate's more is going to be determined, we don't know. But why do we want kids to take a risk when there's a safe vaccine, allows everybody to go to school? I saw some data, 120,000 kids in South Carolina have been out of school because of quarantine or because of the disease.
Right.
That's not good for their mental health.
Right.
So there's all these replications. So, yeah, I'm excited and hope the 5 to 11 can soon get the vaccine. But the concern I have is that if the parent doesn't get it, the child probably isn't.
Right.
And until we can make that inroad and dispel all the myths you've alluded to and the misinformation about vaccines, I just don't know.
Right.
And it's, I'm getting all these emails and phone calls about alternative therapies. I go, the vaccine works. Why do you want to give them a drug where it may not work or it could be harmful? And it can't be a preventive. You can't give everybody ivermectin for 5 months.
Right.
So anyway, I'll get off my soapbox.
No, soapboxes
I deal with it
very welcome to
as they do, and it's frustrating.
So the consensus in the room is that when the vaccine becomes available to 5 to 11-year-old, run, don't walk, and get your children vaccinated, right?
Absolutely.
Yes.
Yeah.
Luckily, we've had some patients, at least I have had some, who are like 16 and the parents haven't been vaccinated, and the kid looks at me and go, I got vaccinated and I didn't even ask them. So they're making those decisions on their own.
Right.
I don't think a 5 to 11-year-old is going to be able to do that.
They don't have that capability. Right.
I am encouraged by some of our youth and some of their opinions. But I will give you some personal experience that I've had as far as vaccine complications. We've had 2 patients in the Midlands since all this started that have had a very mild cardiac complication from their vaccine that was some probably mild inflammation of the sac that surrounds their heart. We treated them both with ibuprofen on an outpatient basis. They did fantastic.
Yeah.
We've had probably 40 patients with a condition called MIS-C, which is a post-infectious disease process that wreaks havoc on your heart. And without aggressive medical therapy, they would probably have long-term cardiac complications. But most of these kids are picked up, and we treat them with IV medications, steroids, all other types of drugs to try to decrease inflammation in their heart. And we'll probably get good results from that. But 40 versus 2, ibuprofen versus steroids and intravenous medications is hugely different.
Right.
So,
yeah.
yes,
Makes a lot of sense.
We encourage the vaccine.
Great.
I feel like there's been so much focus on the mortality rate in children and not as much on the morbidity and all of these things that occur to children. Yes, maybe they don't die at the rate the adults do, but are we okay with so many of our children having long-term cardiac or pulmonary damage?
Right.
And that's one of my big concerns is
Right.
we're not focusing on that. That is such a significant burden to our children that I think we need to consider.
Right. No, I think you're 100% right, and that message needs to keep getting out there, and hopefully we'll turn the corner here soon. We're all tired of this nonsense, I think. So, on a happier note, everybody loves a good success story. Tell me some of your great success stories as a result of going out and serving patients in place.
I can give you some statistics that are kind of a success story. When I was preparing for this, I went back and looked at some of our data that you and I share in the past on these on our outreach program. And last year, the academic year, we saw 3,200 patients in these outreach clinics about. And if you look at about an average of about 80 miles of travel for each one of those patients back and forth from their location to Columbia, it adds up to 256,000 miles of saved mileage that we've been able to accomplish with these clinics. And I thought about that number. I said, that sounds like a lot, but it's kind of hard to conceptualize how far that is. And so I looked it up, and it's 10 times around the circumference of the Earth, or one drive from here to the moon.
Wow. Yeah,
it's a lot of miles.
Yeah.
And, that makes a big difference as far as money and costs and all this kind of stuff. But then I started thinking about the larger picture of the effect on our environment and how much carbon exposure and greenhouse gases
all
we've
those
saved.
Ripple effects, right?
But that's 1 year I'm talking about of 256,000 miles. We've been doing this for 25 years. So if we looked at all the years, I'd love to know what tonnage of carbon emissions we have saved by doing these outreach clinics.
Mm-hmm. Which is a positive impact on childhood asthma, right?
Exactly. So
it's all coming together.
That's a global, a more global program success story.
Right.
If you want to look at individuals, I can't tell you a specific person, but I cannot tell you how many times we have had patients come up to us, or families come up to us, mainly mothers and fathers, telling us how much they appreciate coming to their community.
Right.
And I think it's more than just not having to travel. It makes them feel important. It makes them feel like where they are, and sometimes in the offices that we do the clinic in, it makes them feel like that we're doing something special for their kids, and there's something about traveling to go see someone's child that makes that parent even more appreciative that you've gone to the effort to do something for their child versus just, I'm not going to say just sitting in your office in Columbia, because we don't do that, but it means a lot to them, and they tell us that repeatedly, and I'm sure Heather has stories of that as well.
Yeah.
I've seen one of the biggest benefits are our cystic fibrosis patients who I've mentioned before. We see every 3 months, and the data shows that if they are seen consistently in a certified center, that their outcomes are better. And I can think of 3 specific patients who were seen maybe once a year until we started going to an outreach clinic near their home, and now they're being seen very close to the quarterly timeline.
That's great.
And that's huge, because we know what the data says, and the data says your outcomes are better. So I feel like we have really done right by those patients by being available in their area. Even if they may not realize the medical impact, I know socially, like Dr. Shuler was saying, they appreciate us being in their community.
Yeah, that supportive aspect of it all.
Yeah.
Right. Yeah, and it's really hard to argue against serving care to medically fragile children. That's a population that everybody should be behind to support, I think, in some way, shape, or form. So, and our Center of Rural Primary Healthcare, we're very pleased to support this. And Dr. Taylor mentioned that earlier, and I'm a bad director for not mentioning it first. So we've been supporting this for many years, and
yes, you have. And
we'll continue to do so in the foreseeable future as well, because it's been a great program, and it's done a tremendous amount of work.
Well, we want to publicly thank you for that support, because I would tell you right now we wouldn't be doing 9 subspecialties, and we wouldn't be in 7 different cities. We could not, the costs would not allow us to do that, even trying to serve the children as best we could.
Right.
And so that your center and the support that we get is just phenomenal, and it's having a ripple effect. The kids that Dr. Staples talked about will live longer because of that.
Yeah.
Nobody will ever know it was because we did a rural health clinic. They'll never, ever, ever know that.
Right.
And those are the silent success stories that occur. And Dr. Shuler alerted to about 40. We're over 50-some just in the Midlands now with MISC.
Right.
And those kids, if couldn't be followed up appropriately and everything, it's just phenomenal. And I do think it sends strong messages. So we're very thankful for the support. And we hope y'all take great pride in what we're doing, and that you know that you're a big part of that success.
Yeah, this is one of the success stories we always raise, and especially in front of the legislature. So thanks to the legislature for supporting this as well.
Exactly.
I'll give you a good story, Kevin. It's not necessarily dependent upon outreach, but it relates to our outreach clinic. We were doing an outreach clinic in Orangeburg probably about 15 years ago. And I'm from Orangeburg. I grew up there, so I speak Orangeburg, so I can understand people down there, and I know how they think and how they talk. So a little girl was having an ultrasound done of her heart, and she looked at Mom, and she goes, "Where's the lard?" And I thought, oh gosh, she thinks she's got lard in her heart. And so I went into this long explanation about how, you can develop plaques in your heart relatively early, but you're young and you probably don't have that. We can't really see that in ultrasound. And finally, Mom stopped me and she goes, "She's saying Lord." I said, "Ma'am," I said, I'm going to let you handle this about how you can see the Lord in your heart on the ultrasound. But I should have picked up on that. I should have spoken better Orangeburg, but I was more concerned about the science of it. So that's my favorite outreach story, though it probably could happen in anywhere, even Columbia. But she did have an Orangeburg accent, so that probably does relate to our outreach clinic.
So you get a pass for that one. That's
yes,
good.
Exactly.
Well, this has been a great conversation. I do want to wrap up with a couple questions I ask all of my guests. When we talk about rural and rural healthcare especially, we tend to focus on some of the shortcomings, the barriers, all those kinds of things. But I want to know, especially those of you that go out into rural, what are some of the good things you see out in rural South Carolina?
I love the camaraderie that I see in the communities, especially the community pediatricians' offices that we are lucky to share space with. It's such a supportive environment, and so I always appreciate going out to those areas for that reason.
Yeah, that's good. Ozzy, anything?
I have a couple of examples. One is when we take our medical students and residents, sometimes this is the only time they've ever seen these communities. So I can remember vividly taking someone to Sumter with us, and it was a resident who was not from South Carolina, never been to Sumter, and I remember the comment was, "This is a really nice place." She goes, "I really need to get out more and see more of South Carolina." I said, "Yeah, this is what rural South Carolina is about."
Right.
Everywhere you go, you're going to find good people and bad people, but you can find some really, really good people from rural parts of the state, and the appreciation you see from these people is what's really special.
Right.
They express that, I think, a whole lot better than the people from the big city do, maybe. They really appreciate you being there, and they feel special because you've come to see them.
One final question for you all, and I've asked this of everybody, is how residents from out of state, from New York City, how would you define rural? How would you describe what rural is to them?
Well, I grew up in a small town in Dillon County called Lakeview, South Carolina, and we had 800 the population of the little town was 800. Had a flashing light. And but everywhere else, if you went 250 yards from that flashing light, you started running into farmland, or you started running into pasture land. And I'm sure it's not that way anymore, but I would define rural. I know they have federal definitions, but I think you have to look at what is available in terms of services and what is available to the communities as a whole. How far do they have to travel for things that we all take for granted? And so that's why I think most of South Carolina is rural still, because of the distance. We're all concentrated in a few, we call ourselves big cities, and we're little.
Right.
But if you get outside of that, in McCormick County and Bamberg County, Orangeburg, Dillon, or Rhea County used to be that way, but it's not anymore. And if you get up towards Oconee and Cherokee and Gaffney, and we could just Chester, Lancaster, Chesterfield. Those are rural. Right. And so I would define as by how far you have to travel for the basic services that we all take for granted.
What you described, Kaufman, is, and you didn't use the word, but I'll use the word, is just access. Access, and we think about it in medicine as access to health care and access to physicians and medicine, but that can be access to fresh foods, to a grocery store, access to a bank, access to all types of different things. So that access you can have pockets of rural in the middle of a big city. I know there's parts of Columbia where there's not a grocery store within walking distance of, and that's, you're either going to walk or you're not going to get groceries.
Right.
So I think we can have pockets of rural right in the middle of our cities, but it's all about access and what's available to you. We can work on this project that we do is working on providing medical care, subspecialty pediatric care specifically, but that's about the access. But that's something we can control. But the other stuff is for above my pay grade, I guess you would say.
I hear you. Dr. Staples, anything you want to add to that?
Yeah, I would say that I completely agree with their comment about access. And when I came here as a resident, I grew up in a suburb of Jacksonville in Florida, so there were some rural areas around me, but that's not where I grew up. But both my parents grew up in very, very rural areas in Indiana and Pennsylvania, and so I'd seen what that meant. And so that was really what stood out to me when I came here, and I actually went with the cardiology team as a resident to outreach clinics and realized the reality of the lack of access in a lot of the areas of the state.
So thank you all for this. This has been a great conversation. I think we learned a lot and learned the importance of what you do. And again, thank you all for doing this work. As a person who doesn't deliver care, this is incredibly good care. And I'm so very pleased that we're able to help you guys do this in some small way. So thank you all for coming.
Thank you for having us.
Yes, thank you.
Absolutely. So for more information about what you've heard today or our guests or the programs, check out the show notes for today's episode. Stay tuned for more episodes coming out soon. And if you liked what you heard, please head over to iTunes and give us a 5-star rating. Nothing below that will count. If you have ideas for guests you'd like to hear on our program, please let us know. We'd love to hear from you. And that's all for today.
Thanks for listening to the Growing Rural podcast. If you found the content valuable, please leave a rating on iTunes or wherever you listen so that others can find us. For more information, please visit our website at scruralhealth.org or find us on Twitter at SC_CRPH. This was recorded at the University of South Carolina in Columbia. Y'all take care.